Joining us today in the center, Dr. Pam Brown. She's the Executive Director of Anne Arundel County Partnership for Children, Youth, and Families. That is one of 24 local management boards in the state of Maryland. We'll hear more about that. She's also held leadership positions over the past 30 years in government, the nonprofit sector, and really all of those positions have required her to have an operational understanding of diverse funding streams and how to leverage them. She has a PhD in educational leadership from Florida Atlantic University, and her dissertation focused on the importance of community partnerships in mixed neighborhoods to improve outcomes for children and families. And just to note, she's also been conducting needs assessments at the community level for the past 20 years, so we'll bring that experience in as well. Anna Nuvaj, did I get it?
You got it.
Close? Brushing up on my Portuguese. Anna is the Deputy Director of the Rhode Island Department of Health. She's a clinical psychologist by training. I'm hearing a theme around braiding and blending in psychology. And she also has 30 years of experience in public health, both in the U.S. and abroad. She's helped steer the Rhode Island Health Department's efforts to narrow health disparities and promote health equity since 1998, and has helped launch Rhode Island's Health Equity Zones, which you'll hear more about today, a signature health equity initiative of the Rhode Island Health Department. And with us today also is Pat Valentine. Pat is the Executive Deputy Director for Integrated Program Services at the Allegheny County Department of Human Services. So even her title already speaks to integrating across the different silos. She's responsible for the management of services provided within the County Department of Human Services, both direct and contractual, which requires coordination across program, operational and support functions within the department, including evaluation, for example, research, fiscal, human resources, contract administration, information systems, and communications. A lot of coordination. And Pat places a particular emphasis on leading, planning, and promoting integration of all the programmatic work within human services, and importantly, coordinating and collaborating with affiliated systems such as education and corrections. So we've really got the experts, as Stuart said, the real people. I'm so happy to be able to moderate this panel today, this real world panel. And how we're going to proceed is we're going to kind of do a fireside chat centered around 5 questions. I'm going to give you the questions in advance because I know you're going to want to get to the last couple. So we're going to move along really quickly with the first couple questions to make sure we get in depth to the last questions. So they're going to talk about what's the mission or goal of their organization or agency. They're going to give us an anecdote or two about what work was impeded when they weren't able to braid or blend funding streams. Some real life examples of the problems on the ground. And then they're going to talk about how they've changed that, both what sectors were involved in the changed work in terms of braiding and blending and what funding streams are involved. So we're going to get pretty specific. And then we're going to talk about what was alluded to by the other panelists, what structures they had to put in place to do that, what governance structures, what data information system structures, and what financial management structures, and any other structures that they needed to develop that all-important trust. And then finally, we'll talk about what the challenges they face are and what is still needed in order for them to progress their work. So with that, I'm going to come and join. I might get in trouble if I mic myself here. Great. And I want to start with something fun just to get us revved up. I'm curious, and I don't know the answer to this question, but I'm curious what different sectors you all have experience in. Some we just heard from your bio, so we're going to do a quick quiz. Just raise your hand. Who has experience in health? Healthcare?
Yeah.
Public health?
Yes.
Yeah. How about health insurance?
Yes.
Okay. Human services, maybe child and family services. How about the education sector? How about criminal justice?
Yeah.
How about transportation?
Yes.
Wow, nutrition. Okay, there's plenty more, I'm sure. Anything big I missed, like you were waiting for me to say? Okay, as you can see, we have the perfect panel because they have worked across all of these different sectors that we've been talking about today. So let's start out with that first question and learn a little bit more about your organization. So I'll start with you, Pat, if you can tell us a little bit more about the mission of Human Services.
Well, Allegheny County Department of Human Services was formed in 1996 from a number of other previously separate departments. And so it began to integrate in 1996, and it's been a process since then. There were values developed at that point that basically said that people are integrated. You know, we can't pull out the mental health part of a person or the homeless part of a person. And therefore, our approach to serving them has to be integrated. We also talked about in our mission and values statements, which have evolved throughout the years, about the essential value of each person and respect for each person. And what we have found is that coming back to those values on a frequent basis is really important. We are here for one reason only. It's not for our work. It's for the individuals who we serve. And we stress that with our staff and with our contracted providers.
Thank you. Sure. And Pam, can I say the partnership for short? Is that okay?
That's fine.
Okay.
That's fine. Let me start by saying, good morning, everybody. Let me start by saying that the state of Maryland has had a children's cabinet at the state level since the 1990s. And it was created really as a response to the way that we have siloed human health, criminal, police services over generations. And all of the different secretaries serve on that children's cabinet. And the notion was to create a cross-communication and, where possible, to start creating services that were holistic and family-based. So within about 3 years, they decided to replicate that system at the local level, and they created something called local management boards. The Partnership for Children, Youth and Families, or the partnership, is one of those local management boards. The state realized that if you were going to do that at the state level, there had to be mechanics to push it down at the local level. There's 24 counties and jurisdictions. Every county and jurisdiction has a local management board. The funding to begin with was a blended model of funding. Every department put in a piece, and it was all placed in an interagency fund, which still exists today. It's still called the Interagency Fund, that blended all those pieces together and by formula sent it out to local management boards. At the local level, at the partnership, all of the different child serving agencies serve on my board. So, you know, the head of child welfare and so on, the superintendent of schools serve on my board, along with citizens and others appointed by the county executive. We are tasked with being the neutral convener of all things. I am the staff person to that board. I am not the board. I'm the executive director. So my goal in life is to be the neutral convener. I think if you're talking about funds, it's also called a trusted broker, who brings everybody together and says, you know, never mind what's happening with a child in education. There are all of these other issues in families that need to be dealt with, and we need to deal with it in a cross-systems way. So it was a way of sort of forcing a conversation among all of the different agencies at the local level. And what we do is we assess needs, we figure out the gaps in services, and then we find funding to fill those gaps in services around the 8 statewide results for child well-being. It's a pretty complicated system. When I first got there was a lot of money in the interagency fund. It was still a very blended, you know, and well-funded system. Come the recession, the whole thing collapsed. I'm cutting to the chase here. And I became a person who learned how to braid funds and go after funds in every which way I could to try and continue the work forward. And I will talk more about that braiding and to some extent blending as we go.
Thank you.
Thank you.
Anna, how about in Rhode Island?
Good morning. Rhode Island is a small state, the smallest state, as you all know. or should know. We have around 1 million people in the state, and what's unique about Rhode Island is that we do not have any local public health infrastructure. So as a state public health department, we act both at the state and local level. We have the same core functions that any other state public health department has: control of infectious disease, health promotion and wellness, environmental health, maternal and child health, the state public health laboratory, medical examiner's office. Those are the core public health functions, and we exercise them as any other state. I think what's unique about Rhode Island is in the absence of having a public local health infrastructure, we needed to create that local public health infrastructure, and we did that through the initiative that I will be talking later, the health equity zones. We have 3 leading priorities that define the work that we do across the department and across all programs. We have a focus on the elimination of disparities and on achieving equity for every Rhode Islander. We have a focus on addressing the social and environmental determinants of health. And we also have a focus on making sure that the health system, and we make a point of saying the health system and not the healthcare system, to be able to make sure that we are including community services, home-based services, all of the services that are provided, that the healthcare system is of quality, ensuring the quality of that system, but also assuring access to our most vulnerable population. So that's, on a nutshell, how we have made priorities in terms of using a same framework and the same lens across all different aspects of the health department and translating that at the local level. And I will say that later.
Okay. All right. Well, I guess suffice it to say that you couldn't achieve any of your missions without working across sectors, right?
Absolutely.
We know that for sure. So tell us a little about that. Can you each give me an anecdote? Maybe we'll start with Anna this time. Just a quick anecdote about what went wrong due to lack of flexibility to be able to braid and blend. You know, some service you weren't able to provide, something you weren't able to do that is a part of your mission. It could be something very small.
I mean, think about every other health department has followed the Healthy People 2020 indicators. And as any other state, we have success in some areas, we have missed out in some other areas. But when we looked at the data, a deep dive on the data, and you start looking at the data by race and ethnicity, by gender, by geographic location, whatever way you are peeling off and analyzing the data, we see that we have ongoing disparities, and that even where we achieve success and achieve our benchmark for the population, we had pockets of need that were not being addressed. And so I like to tell stories. So I think about 30 years ago, when before I came to the United States, you all figured it out by my accent and by my last name. I used to work in Cape Verde, small group of islands, and as a mental health coordinator, I was dealing with a population that was homeless, that didn't have employment, all of the things that we talk about. I never used the word social and environmental determinants of health, but I was working with the police, with the schools, trying to even reach out those folks. Fast forward, but Cape Verde is poor. It's one of the poorest African countries. Fast forward 30 years later, I'm here in the United States, and I'm having those same conversations. I'm faced with those same challenges. We're talking about housing for our opioid crisis. How do we deal with housing? How do we deal with homeless population? How do we deal with obesity policies when you have neighborhoods that don't have access to safe food and vegetables, that don't have access to a safe place to exercise? So what is that went wrong? I think everything that we do in public health has been traditionally done in a siloed and has not worked, because we still have, in fact, for the first time, in the United States, a decrease in life expectancy. For the first time, the next generation, my children, have a lower life expectancy than I have. So what are we doing right?
All right. All right. Well, that's hard to follow, Pam, but you can give a small anecdote. And now we have the big challenge on the table.
So let me base it on our needs assessment. We're a wealthy county, and Arundel County is a wealthy county. But there are pockets of poverty all over the county, and a very bad one where every single social determinant of health is rising is in the zip code 21225 that abuts Baltimore City. And everything you can imagine is there in terms of rising social determinants. And we just done the needs assessment. It was very clear. You could draw a picture of the map and where race inequity, ethnicity inequity, and rising social determinants lit up in this zip code. Well, there is no funding source for that. There's no big place you can go and say, we've got this crashingly bad situation with poverty, families in massive distress. So we started by gathering together a few stakeholders, and we found a model that is a Casey Family Services model called Communities of Hope, and we created a community of hope. And I think that was important because it gave everybody, every single agency, and all of the agencies who were addressing in silos those different social determinants, a geography to focus on, but also a single agenda or a shared agenda. We use the collective impact model a lot in our agency. And so our shared agenda was to reduce poverty. Obviously, the agenda within that was to stop those social determinants rising however we could. So over time, we started this 4 years ago now, back in 2015. There were 3 of us in a room. There are now 200 of us when we meet. And we have many, many different initiatives going. We have reduced poverty by 0.3% over 4 years. But we will take it because I believe maybe it would have even gone up had we not been there. So I think the important thing about that and about all of this work is the relationships that are formed through it and the people who are doing it. Everybody has to feel good about the work. Everybody has to own it. Everybody has to have the same agenda. And everybody has to be able to sell it to their silo. So you've got to be able to explain why you are spending child welfare money in a library. And so I think all of those issues, and I'm sure we're going to talk about that a lot later, but the personalities that are part of this and the way that we drive our agency heads to a certain set of outcomes that are very specific and narrow outcomes make the work very difficult. Shared outcomes, shared agendas, and relationships are what drive it forward. We started off with a small amount of $20,000 from Casey Family Services in 2015. We now have about $8 million rolling into that zip code to address social determinants of health.
Wow, that's amazing.
Yeah.
How about in Allegheny County?
Well, in Allegheny County, as an example of what went wrong, we have many families in child welfare who are in child welfare basically because of the addiction of a parent and all of the issues that engenders. When we faced this situation, parents were often very reluctant to go into treatment because if it was a mother, or actually more recently even a father, they could take kids under 12, but not kids over 12. And if there were no beds in those family programs, they would have to have all of their kids placed. And if they had no relatives or friends who would take the kids for a period of time, they went into foster care. And once a family gets into the child welfare system, they tend to stay there longer than they would like to, and than we would like them to. So we will be opening in a couple months a family residential DNA program. And this is a program that will hold 8 families at a time, where the entire family, or the part of the family that wants to, can move in. Because, you know, we talk about addiction as a family disease, but we treat the person. So at this program will treat the family. This is being done by Braiding, drug and alcohol funds, medical assistance funds. We are the primary contractor with the state of Pennsylvania for behavioral health choices, which is the Medicaid managed care program in Allegheny County. So we have control over that, you know, basically that funding. So it'll blend the Medicaid funding, base drug and alcohol funding, and child welfare funding. Also, we do have foundation funding to start the program off. So that is just one example of something that was really problematic that we are trying to save and or trying to fix, and using braided funding to do it.
Wow, that's great. That moves us right into the next question. But I'm just summarizing. It seems like, the big problem was that you weren't achieving the outcomes you needed to achieve, particularly when it came to reducing inequities. I'm hearing that from all of you. So, but you're changing that. That's why you're on this panel today. So thank you so much for being here. And I know people are super curious to get a little bit into the weeds on technically how you do this, because that helps us to get then to the policy issues that we can move forward to overcome some of those challenges that you have. So maybe we can pick up and start on that, because you were already giving us an example of how you've been able to solve at least one problem in your community housing and treating families that are affected by addiction, so important. So tell us, okay, you were able to bring those funds together. I know a lot of us, when we hear braiding Medicaid with other funds, red flags go up in our head. What happened when you tried to do that? And what you told us about what sectors were involved, right? Child welfare, behavioral health, Medicaid, obviously, your agency. And you told us about some of the funding streams. So what were some of the, challenges in braiding those together, and what did you have to do to overcome those challenges?
One of the challenges most of the time involve people. And it's not the money. I mean, well, it is the money to some extent, but it's the people. Because let's face it, the staff who are staffing our systems today professionally grew up in siloed systems where this is what this money is to be used for and nothing else. And the fact is that most of the categorical funding is categorical for a good reason. It was categorical because somebody was trying to protect a certain population. Somebody wanted to make sure at the federal level that pregnant women with children had access to DNA treatment or access to DNA prevention, or that people, I won't go through all the examples, but you know what I mean. And however, even though they had a benign intent in the beginning, they're now, in terms of integration, problematic. So, and our staff, we grew up in that siloed system. So the biggest thing is constantly harping on people are integrated, and if the funding is not integrated, then it's problematic. This doesn't happen in fiscal. First, you've got to have an integrated fiscal staff. Because if you have a fiscal staff where one unit is responsible for mental health, in the Department of Human Services, we have behavioral health, including MH, DNA, early intervention, aging, intellectual disability, child welfare, and community services, which is where our housing, homelessness, food programs, and Head Start goes. If you don't get people to understand that they need each other in order to accomplish their goals successfully, that's where the biggest challenge is, and that's where I spend most of my time. And I'm constantly saying, how about this? How about this? And we can talk about that later.
Yeah.
We're running out of time here.
There's a dose of reality, but it sounds like So people issues are the most challenging. So we have workforce training and various policies, right, that we can put into place to try to improve that. But it does sound like your agency is structured to have that integrated fiscal structure, right? Because you just described a plethora of varied programs under your agency. And that's a little different than you as the neutral convener, right?
Yes.
Yeah.
So the partnership is what's called an instrumentality of government. We don't get any county funding, but all of our funds run through the county financial system. So counties, or at least our financial system, runs by business units. They live in a world of business units. So for every new piece of funding you get, your poor fiscal manager has to open a business unit and keep that business unit clean. So you can imagine if you've got different amounts of different funds coming from different places, how the poor fiscal people are constantly trying to manage their business units and figure that out. They are most frightened of federal funds. Federal funds are the nightmare of all funds. Let me tell you, my finance manager dreams about federal funds all the time because we're constantly afraid we'll go to jail. So we have federal funds, we manage state funds, we have county philanthropic funds, we have individual donations, and we work on several years. So we work on the federal fiscal year, the state fiscal year, which is obviously July through June. We work on a calendar year with foundations, and then we work with whenever donors want to give us money year. So you can imagine our county fiscal department, who is used to managing, let's say, public works and a certain set of funding, has to manage this crazy little agency who isn't even part of a line item budget. It's very, very difficult for them. It's also very difficult for us to explain to them what we're trying to do. The only success, I would say, in blending that we've had working with our county fiscal people is when it's majority philanthropic funds. And that's always because it's less accountable, because individual donors basically want to know that you did something good for a family. So they're happy if you did something good for a family. If you then start moving that into county granting systems, into other systems, then all of the fear of you misspending public money, which is really what it's all about. It's fear of misspending, it's fear of supplanting. For those of you who manage federal funds, the dreaded word supplanting, that's the go to jail word. You will go to jail if you supplant funds, which basically means you use federal funds and another set of funds for the same thing. So imagine when you're mixing funds together, how easy it is to fall into the trap of supplanting. And there's no accident with the federal government. You can't claim you did it by accident. The bars look the same. So so really, the issues around finances are to do with funding streams, and then how whatever your agency setup is, whether it's a county setup like mine or a state setup or even not-for-profits, how you then manage that inside an accounting system so that you actually get a clean audit, which is what all financial people want. They want a clean audit. And so the dangers in braiding and blending is that will not happen, that there will be audit findings that then create a corrective action plan.
Absolutely. Well, I want to just draw out 2 points that you both have made that we hear a lot. And one is that categorical for a reason, right? So coming back to that, we do hear fears about, what happens if we braid and blend these things together, right? And then what happens if it becomes maybe a block grant and then is reduced in future years? Yeah. And even from, the political perspective of the advocacy for those different pots of money that were categorical, again, for a reason, if we use them differently, will we still be able to maintain those funds that we are able to maintain through the kind of sector-specific advocacy, right, or issue-specific? So that's a really important point you're raising. Also around the fear. And we laughed, but this is true. And we hear this a lot from states. Sometimes the government will offer some flexibility, but states won't adopt it. And why is that? Because they're afraid. We hear that big inspector general, coming down on you. And this happens. It happens in the schoolhouse space, for example, where, and those people have long memories of those things. Like, we did that 20 years ago when they told us we could, and the inspector general came and took millions back from the state, and I lost my job, you know? So those fears, we laugh, but I think it prevents states sometimes from taking advantage of opportunities or localities, right? Those fears. So we want to hear it from Anna now about the health equity zones that you alluded to earlier, because it sounds like while your agency is also, you know, has a varied programs and integrated structure, even though it's still within one sector, you set up this initiative really to do a different level of integration that occurs across the rest of the department, right?
Absolutely. And in fact, it's now also occurring across state government, because it's not just the health department that is investing in the health equity zones. So if you go back to the point of believing that what determines our health outcomes, it's things such as housing and education and jobs and schools, quality of schools, all of that. Public health is so good at telling people what to do. We say to people, don't smoke, which is a good thing. We say to people, we exercise 30 minutes a day, eat your fresh fruits and vegetables, but we don't really look at how can people truly exercise that choice, do that. How can that happen at the local level? So the health equity zones was our commitment to our local communities to truly listen to the communities, go back to the basics of asking the communities what is that is important for them. How do they define health? What were their health priorities? And how do they want it to address those priorities? And so we ask communities to draw a line on a map, define their zone, what they call their health equity zone, to come together, key stakeholders from the community, do a needs assessment, do an assets assessment, come up with, through a community prioritization process, with their priorities, develop plans of action that were based on evidence-based programs, and then we funded them. How did we fund them? We braided funding. We braided federal funding with state funding, and we use categorical funding. We use block grant funding. We truly created a thread, the thread that you saw at the beginning, with CDC funding, or HRSA funding, CMS funding from state innovation models. So we were fearless. Because even on the categorical funding, if you really read the guidance, they all say for us to address racial and ethnic disparities. They all say for us to address the social determinants of health. So we are doing what the federal government asked us to do. We are addressing those determinants. And so as folks develop their plans of action, we use the block grant funding, HRSA, prevention block grant, to really address more of the infrastructure needs, the state funding to address infrastructure needs and cross-cutting issues. And then depending on their plan of action, we pull funding from the thread and the braid that we create. So if a community says that they want to address diabetes as a priority, we pull funding from the diabetes categorical funding to fund that initiative. If they tell us that they want to do a sidewalk, which there is no categorical funding for that, we pull funding from our state general revenue. If they say they want to address community relationships because their adolescents are having trouble with police relationships, we can pull funding for maternal and child health, because maternal and child health is supporting early, healthy adolescent development, and we claim and propose that that impacts healthy adolescent development. So we created this structure where we were able to braid the funding, which keeps the categorical integrity of the funding by pooling specifically then to fund at the local level. Is it hard? Absolutely. Is it challenging? Absolutely. But we created that system, accountability system, at the department level, and at the community level. It's not. We deal with the burden and with the challenge, and we support the community by funding them that way. And because their work plans are connected with that funding stream at the back end, we are able to then report back to the feds for every penny that we spend, how it was spent. And we did pass the audit general without any funding.
We always talk about
any funding.
All right.
So I think that is success.
We have time for just really one more question. I want to make sure that you guys get to say what you want to say. So we'll leave this pretty open-ended, but I think we do want to dig more into the challenges. So you've talked about how you've overcome some of them with integrated fiscal management structures, with ways to be able to account and track, as Stuart and Sandra were talking about on the first panel. One of the things you haven't mentioned, and I wonder if anybody wants to bring into the conversation, is they were talking about the data sharing. And I wonder if you wanted to bring that into the conversation. And I realize we have two government and one quasi-governmental agency here, right? So governance, but governance still does differ. You didn't really raise if there have been any changes to your governance. So I'm curious about the data sharing and the governance. And we always use those three categories, kind of a governance, information systems, and financial management. But maybe there's another category, it's probably in the workforce development, I'm suspecting, that we should be raising up as important policy areas.
I think all of that is true. So from a data sharing agreements, while we have data share, we didn't need data sharing agreement within the health department. As we start receiving funding from other agencies, CMS, from SIMS, etc., we needed to create those agreements. But that's not hard to create. You have your legal department, they figure it out and it's done. It may take time, but they've always figured it out. I think the issues of trust and the issue that you raised in terms of relationship and people, it's important not just from people being used to work like this within their siloed, but it's also because they feel accountable to that funding. And it raises anxiety at the staff level when they are being challenged by management to do things in a different way. So workforce development is an important component, being able to engage and train your staff to be able to look differently. So we did create a series of supports and trainings in terms of how to write grants. So this story that I'm telling you is the story that the diabetes program manager is telling when they apply for funding to CDC for diabetes. Because like that, the authorization comes from the feds and they cannot tell after, oh, I didn't know. They knew. We said that in our grant application. If they didn't pay attention, that's another problem.
Right.
But we did say it very clearly that that's what we were going to do. So you need to train the staff. And you have a lot of issues with the federal agency because we all know that our relationship is with project officers, and so it changes from one to the other. So there is a difference between your relationship, programs, and project officers, and then at the leadership level. And so that's another challenge, how much you can push the federal, our federal funders, push back at them and have that ongoing engagement. Relationships are important. I say it's people, but it's more relationships that you build with your staff and with the federal agency and with every other partner. So you build a trust and they allow you to really challenge yourself and the system so you can do things differently.
Thank you, Anna. Did you want to raise something?
Data sharing.
Okay.
Well, of course, if you are trying to create family systems and family outcomes like well-being, you need data from all of the systems that you are working with, so child welfare, health, education, and so on. We created an innovation project about 7 years ago that was based around kindergarten readiness and early childhood, and there were many partners, including social services, health, and so on, the education system. And we started out very bright and bushy-tailed, thinking we are going to do something wonderful here. Everyone will see it's an innovation. Everybody will want to share data. It's going to be a fabulous thing. Well, first of all, everybody's data is kept in different systems. I'm not even going to start with all the confidentiality issues around it. Let's start with the systems, the clunky old systems, the systems where you can't even pull out an Excel spreadsheet of the data that you want because the system won't allow you to do it. The systems won't talk to one another. Then there's all the protections on systems. So there's the HIPAAs and the BERPAs and the FERPAs and all of those things. So we looked for a software system that might create the sorts of firewalls that would allow you to, if we could even figure out how to pull the data in to protect the data and actually share data that was de-identified and would have a single indicator and all of that. So we found a software system called Efforts to Outcomes, which was the only one at the time that will actually allow, I'm sure some of you know it, will actually allow, and we managed to persuade the school system to buy it for us. And then we spent the next 3 years bouncing between attorneys at the state level around sharing data. The only data we managed to share was our data within our different programs, some Head Start data, and a little bit of health data. We still are moving that forward. We are still trying to talk to the state about how to do it. But what happens is we had an MOU for 5 years. It kept going to attorneys who would mess with the language. Then it would go to the next attorney and said, I don't like that language. That has to go back to child welfare. Well, we're not doing that set, and so on. That MOU still has not been signed. Three of the original attorneys are no longer there. All of the secretaries are no longer there. And we are really back at ground zero with that. So I would say that data sharing across silos is horrendous, especially if you want to know that you've made any impact with the initiative that you've started. It's so important and it's so difficult. In terms of governance, I've explained our governance to some extent. I think I'm very lucky because I actually report to county government as an employee, but because they don't pay me, they don't really know what to do with me. My board is an advisory board, so they don't really know what to do with me either. So for this 10 years, it has been Pam Brown's perfect job because I don't have a boss, which means I should say, Stuart, I love you. I'm sure you're watching somewhere. But it means that I have a lot of freedom. So in terms of governance, I would say not having any is great. But my local management board is obviously all of the child serving agencies. We've added a guiding coalition to that of consumers who use services, including youth. And we have strategic advisors from sectors. So like we have the caucus of African American leaders who is a strategic advisor for any new initiative and sort of kisses and blesses it and says either that's terrible, Pam, or okay, we'll give it a shot. So we have 3. We have one for trauma, we have one around homelessness, and we have one for the African American caucus. So that's how we do our governance. But I'm sure you can tell it's very local. It's very anachronistic, so when you start dealing with big systems, it's much harder to do those things.
That's incredible engagement. Yeah, really. Do you want to add something, Pam, before we move to Q&A?
Our local foundation community invested heavily in our data warehouse. So our data warehouse is considered a community asset. It's got information not only from human services, but from criminal justice, education. We've got data sharing agreements all over the place so that, and our data folks have developed an application called Client View where we and our contracted providers can go into this application and see the systems in which any individual client is involved. And it's wonderful from that standpoint. The issue, we still get oh, that's confidential, you can't have this information in there. However, we have taken the position and have legal opinions that say as long as the agency is serving that person, that they, for the purposes of continuity and coordination of care, are able to access that information. And I will stop there because we're a bit over.
Well, no, we're not over as a panel. We have now time for Q&A. So that was a good trick that he did with the timer. So I know about half of you in the room, so I know you have questions. But if you don't mind just telling us who you are and who you work with as you present your question, there's someone here with a mic who can come to you. I know one right in the back wall there.
Hi, I'm Michael Shea. I've been on a lot of advisory committees and commissions for Arlington County or across Northern Virginia. My question has to do, if you get beyond the data sharing challenges, what do you need to do so that local units can use the data effectively and learn from it and adjust programs? Because a lot of agencies have a monitoring evaluation cycle that can be years long, but you've already maybe tried something new and you've learned from it, but you haven't been able to change your actions.
Great question.
Repeat the question.
Oh, could you hear it?
No.
He was asking, when you get beyond the data sharing, how can you actually work with the business unit to use that new information that you have effectively because of the long monitoring and evaluation cycles you sometimes have in place? Did I get that right? Okay.
So speaking for Allegheny County, we use it primarily in two ways. Number one, for analysis. We've got an analytic team that is really very good and in which there's been significant investment. So we use it for analysis, and that provides information back to the program staff about what is working, who they're serving, in a more than surface view. The second thing, though, is it can be used for day-to-day programs. So when a child welfare worker looks into client view and sees that somebody has bounced around to 5 different DNA programs or mental health programs over the past 6 months, it provides some ability to ask questions about what's been the problem. And so we use it practically that way. And also if somebody, is sort of trying to hide the fact that they have a DNA problem, the client view does provide the actual information to the provider. So we use it analytically and practically.
In Rhode Island, one of the uses that we've done with our local health needs assessments from the community provides a better story about public health and what's happening really at the local level that most times your survey data doesn't allow you to have that point of view. But the other practical use, we used it for our accreditation as a health department that was truly led by the community. And then we are using it today with our hospitals. As you know, the ACA requires all of the hospitals to do needs assessment. So we are connecting those assessments that are happening at the local level as fulfilling that requirement, but then asking hospitals to invest in those local needs assessment identified priorities. So it's driving the investments at the local level.
So we're creating, and have been for a while, a public-facing dashboard. We use something called results-based accountability, which basically asks, is anybody better off because of what you did? And we're really into well-being and how you measure well-being. So that public-facing dashboard will be simple and will be open to the public to see what progress we are making in basically holistic initiatives and strategies.
Thank you all. Any other questions to Debbie?
Hi, everybody. I'm Debbie Chang with Rhode. This was a great panel. Thank you, Ann. And really great examples. In each of your examples, it really sounded like you really did workarounds around the current system to make it work, which is what you have to do.
Yeah.
I'm just wondering what your thoughts are, especially I'm thinking of all of you, but Anna in particular. How do we change the current system so you don't have to do those workarounds? I think that's the issue of policy at the state and federal level, and some of it you've mentioned already, right? That there was more flexibility in, I think, HRSA and the MCH block grant. But what other things could, in terms of the policy issues, what other things could we be doing to make things easier for you all and still be able to provide the funders, meaning both private and public, the kind of accountability that they need? So that's one question. My other question is about, a lot of folks get their care through managed care organizations, and there's actually a lot of flexibility in terms of how they use their funding. I'm just wondering if they're involved, particularly in Anne Arundel County, whether they were involved in the behavioral health work. Mm-hmm. So those are two questions.
So from a state perspective, I think some of the challenges, some of the policies that would need to change were alluded at the beginning by the first panel. I think at the federal level, from a grants funding perspective, to have more alignment in terms of timeframes and the budget year for every grant, which varies from agency to agency and sometimes within the same agencies, a better alignment in terms of reporting requirements to states, and creating that flexibility because, for example, when they had the famous, it's nicknamed 1305, which was an integrated chronic disease grant, it was integrated, but it was not because then we needed still to report back by disintegrating the grant. So truly having that alignment in terms of reporting financial, that will be a a needed policy change at the federal level. But then at the state level, I think if you truly look at the guidance, it has more flexibility than one thinks. And challenging back the federal government by telling your story differently. We usually read a guidance and you think you are responding by saying A, B, and C exactly as it is. But if you truly read and tell your story, they then approve it. And you now have a framework and an approval from the federal government to do that innovation that you need to do. So it's challenging yourself as a state, but also it's challenging and asking of the feds the flexibility in terms of grant making and grant funding that needs to exist. They need to talk to each other the same way we are talking.
Yeah, yes. So I think the federal government is becoming more rigid in terms of what I see. One of the things that is an example of their rigidity is now their request for timesheets for every piece of work that we do. So if you think that most of my employees are funded by blended funding across 5 different funders, their timesheets become this nightmare of how do we make sure that they are correct to the funding source. I mean, just me sitting here, I have to think about where is this 8 hours going to go, probably into general fund because that's the easiest way to explain it. But more and more, it's not just federal authorities, but federal authorities particularly are asking for minutiae in terms of how the money gets spent. And I understand that's around protection of public funding, but it becomes that we are spending all of our time accounting for how we are spending the money rather than spending the money for the public good. And I actually believe that that's not what the federal government means. So I think that the flexibility around funding is incredibly important. I just want to echo what Stuart said at the beginning about leadership. This is so much about leadership at a small and big level for those of you who run agencies, for those of you who have departments. This is a behavior of encouragement because we are discouraged from collaborating. We are praised for what we do with our silo, with our section, with our department, with our state agency. We are not praised for behavior that is not that actually gives praise to others. So I spend all my time trying to think about where's the enlightened self-interest for everybody I work with, because I've got to find a way for them to look and feel good about the work that we do. Leadership will figure out how to make the collaborative behavior, the praised behavior, the wanted behavior. And that's up to all of us to do whatever level you're working at. I'm not going to answer the MCO question because I think I'll do a really bad job of it, so I'm going to pass.
Thank you. I'm happy to answer the MCO question. We contract with a behavioral health MCO that is very involved in everything we do. They understand that if we don't address housing and education and basic needs like utilities and food, that they are going to have higher bills. I mean, that's the way it is. Exactly. So they work very closely with us. And as one example, they funded a program called Helping Families Raise Healthy Children. And basically what this program was about was when our early intervention, birth 0 to 3, staff went into homes and found that a mom or a dad was depressed. We developed this program paid for by the MCO where therapy staff and case management staff would go into the home. And for the period of time that was necessary and work with that mom until she was able to go into treatment at an agency or with a practitioner, or she didn't need it anymore. They paid for that. It was a huge success. And in fact, if you just Google Helping Families Raise Healthy Children, you can learn a little bit about it. But that's just one of many examples where our MCO was right with us because they understood it's not just the mom, it's the kids. So Yes, they work really closely with us.
Thank you so much. I think, unfortunately, even though I know I wanted to get to one more question, we are out of time. So I guess I would just ask our panelists if they'd be willing to, hang around at the
Sure.
end of the program at 11 today, so that we can have our one next panel. But I know people want to ask you some questions, so please join me in thanking Anna, Pam, and Pat. Thank you.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.